Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights from the August 21st issue. Among the most exciting developments recently in cardiology has been the development and availability of new antithrombotic agents, the thrombin inhibitors, dabigatran, the 10A inhibitors, rivaroxaban and apixaban. And of course, there have been no head-to-head comparison of these agents, and so most of us clinicians are wondering at the moment which of these agents is preferable. And to try to answer this question, a group of investigators from Europe undertook a comparison, an indirect comparison, using warfarin as the comparator. So they had data comparing dabigatran, rivaroxaban, and apixaban, each against warfarin, and used that to relate one to another. And this is a very, very controversial undertaking, but nevertheless of some interest for us at this early stage of availability of these agents. And they found that dabigatran had a lower stroke and systemic embolism rate than did rivaroxaban. However, of course, the patients in the rivaroxaban study, the ROCKET-AF trial, had more advanced disease. There was no difference for any of the agents for ischemic stroke. In terms of bleeding, there was less bleeding found with dabigatran, with apixaban rather, than dabigatran 150 or rivaroxaban. Now, overall, these investigators, having done this extensive analysis, felt that the most important finding is that there were no profound differences in efficacy between these agents. So given this, it seems to me that our choice of agent is likely to depend on other characteristics such as dosing or renal failure or things of that nature. Now, again, to repeat, this is an indirect comparison. The patients included in the various trials differed. The therapeutic regimens differed. This can hardly be taken to be the same as a direct head-to-head comparison, but nevertheless, I think does serve to put these various agents in perspective relative one to another. The role of statin agents as antiarrhythmic drugs continues to be debated. Now, the statins do have pleiotropic effects that might be of value, such as their effect on ion channels, heart rate variability, and on the QT interval. However, it remains uncertain whether these are truly of value in the clinical setting. Now, for patients with ischemic cardiomyopathy, it's not an important issue since most of those patients are going to have a statin indication anyway. However, it's much more relevant for patients with non-ischemic cardiomyopathy. And to try to address this, the investigators from the MADIT-CRT trial analyzed the results in 821 patients with non-ischemic cardiomyopathy. They looked at the patients who had statins versus the patients who did not, and they found that the statin patients manifested a 77% reduction in ventricular tachycardia, fibrillation, or death, and a 46% reduction in ICD firings. So the statins did appear to be effective in this retrospective analysis of the MADIT-CRT data. However, we have to keep in mind this was non-randomized, retrospective, and that all of these patients were unique in having heart failure and meeting the CRT requirements for the trial. And would I, at this point in time, begin my non-ischemic cardiomyopathy patients on statins? I think on the basis of these data, probably not strong enough. But I certainly think that they represent sufficient data to generate a true prospective randomized trial. The pathophysiological mechanisms underlying aortic disease, particularly aortic dissection, remain uncertain. And to try to assess this, a group of investigators looked at S100A12, a protein sometimes called calgranulin, and they looked at its role in patients who had aortic aneurysms and dissections. Now, S100 is an inflammatory protein that accelerates atherosclerosis, predicts coronary disease, and importantly is found in ruptured coronary plaques. And so these investigators analyzed for S100 expression in the aortic tissue of aortic dissections and aneurysms. And interestingly, they found expression in all patients who had aortic dissections and 25% of patients with stable aortic aneurysms. So that this is an intriguing finding. This is an inflammatory protein. And this S100 calgranulin may in fact be a target for either diagnosis or therapy in aortic disease in the future. We were pleased to have these interesting papers to publish in JACC. For Inside JACC, I'm Tony DeMaria.